actually happening, and I'll bring up the case for change as well. I will talk a little bit about the engagement, the plan, of what the engagement plan is, and then we'll actually go into the workshop, and that's going through. We've got about 10 questions that we want to get your feedback on, and then have a bit of discussion, question and answers, and then we'll explain the next steps. So if everyone's happy with that, I shall hand over to Scott, and I shall share my screen and bring up the case for change document.
Okay, I'll just give a little bit of a summary then of the case for change. So I think it was probably autumn time of 2020. There's some clear guidance came out from NHS England that all CCGs back then, so clinical commissioning groups, were requested to establish post-COVID assessment services extremely rapidly. And I'm afraid to say in Derbyshire, we managed to set ours up back in December 2020. Now, that service was put in place there to provide assessment to patients coming through the service and to identify some symptoms and any support and services we could signpost those patients onto. Now, fast forward to April 2022, the service grew to include rehabilitation. Now, in terms of the rehabilitation side of things, there is hubs established in the north. So we have a hub based at Chesterfield Royal Hospital, and there's a hub established within the south, which is at Florence Nightingale Community Hospital. Now, in terms of the rehabilitation offer which those services both provide, the key areas is around respiratory and breathlessness, vocational rehabilitation, fatigue, and health psychology. So those services have been in place now for a couple of years. Now, why is this service being reviewed? So there are two key drivers behind that from why we're here tonight. So the first key driver is referrals to the service have gone down. So you can see from January 22 to February 23, referrals have averaged in the service, and they have peaked at times, gone up and gone down, around 20 referrals per week. Now, over the past 6 to 7 months, and this is in line with national and regional trends, those referrals have gone down to around 12 per week. So from around 20 a week to 12 per week. So that is one of the areas what we would look at to ensure we provide value for money there. And then the other key driver behind this is funding for the service is due to reduce in April 24. So for those who may or may not know, this service is fully funded centrally by NHS England. Okay, and basically quite recently we've been advised, due to the reduction in referrals which we're starting to see regionally, we also expect to see a decrease in funding coming down centrally. So they're the key reasons why we're here to discuss today. Is there any questions at all which anyone would like to pick up? Sarah.
Thank you. I suppose being a bit controversial really, but sitting on the National Task Force, there hasn't been any mention that the funding will reduce next year. What we've all been told is that the funding will remain for 24-25 as it is for 23-24. That's my understanding. Secondly, I think there's such a big, I think referrals dropping, it's not as simple as there are fewer people getting long COVID. It really isn't as simple as that, and I'd really like to be able to discuss that. I'm sure other people would probably like to discuss it as well, but from my point of view, I was involved in the Midlands peer review of long COVID services in Staffordshire, Lincolnshire and Leicestershire. They ended about 6 weeks ago, and I was the lived experience partner talking to patients, and there were so few patients that had actually been referred through their GP. Most of them had had a dreadful experience trying to get referred because of the poor messaging around long COVID and in GP practices. I took this back to the head of engagement to the medical director for primary care, Kieran Paulson, and to Aaron Mills, who's the head of public health and system engagement, and they took it to the UK Health Security whatever, and they're not prepared to do anything about improving comms, but they are prepared to work with charities who are working on comms around long COVID. I've completely forgotten what I'm saying now, but I think that the big message is what needs to improve, and we can only, I guess, here start in Derbyshire, is comms around the only way not to get long COVID is not to catch COVID. COVID is still there. Living with COVID doesn't mean ignoring it. And I'd really like to see something like that approach in the Derbyshire ICB.
Okay, thanks, Sarah. Scott, do you want to come back to that?
Yeah, so the first part of the answer, that's the verbal advice we've been given by NHS England in regards to the funds. So there's been no formal confirmation in terms of funds to date. And the second part of that, you are quite right there, Sarah, whereby this is a GP referred service. So this is not a self-referral service. What I can say is that in the Case for Change document, it goes into it in more detail, but we have put some support and resource looking at health inequalities and how we can reach out to promote the service. So there's some information there as well.
Okay, thank you, Scott. I'll come to you then, Michael, after.
Yeah, okay, we have two things in the chat at the moment. So first of all, from Gemma, she said, this is the problem. GPs do not understand and some do not believe in long COVID.
Yeah, so in terms of the understand element, that's one I can certainly answer. Probably don't think I can answer the second part of that question, but the first part of that is GPs were involved with the establishment of the pathway, and they've all been provided with information and education of the service itself, and that's ongoing information and education as well. So I would like to think that GPs do know about that service, and maybe I could bring Fozia in here as well, is that obviously there's that ongoing training and support which is provided to primary care as well.
Just take my mic off. Hi everyone. So in terms of the kind of work we've been doing within Derbyshire to support our GPs in terms of increasing their engagement with the post-COVID service, increasing their knowledge of long COVID and the treatments available that their patients can be accessing if they are referred to us in the post-COVID service. And also more nationally, I've been working with the national team in terms of creating work packages for GPs across the country to access through Health Education England to understand long COVID and post-COVID services better. So these are kind of different things that we've been doing to try and get our GPs engaged more and try and get our GPs more educated on long COVID. We know that there are pockets of different areas across the county where referral rates may differ, and we are conscious of that, and we've been sort of doing particular education exercises, things like GP task force, LNC, the local sort of GP groups, going there and talking to them about what long COVID is and making sure they know about the service. And we'll be doing sort of little exercises like that just to see if it makes a difference in the referral rates of those particular GPs that we are aware that don't tend to refer as many as others.
Thank you, Fozia. I'm just going to say that if we do 5 more minutes of questions, I'm just conscious that we'll actually want to get on with the engagement. If there is any questions left unanswered, if you put them in the chat or email us, we will get back to people as well. So don't think that that'll be it. Michael, I'll come to you.
Yeah, so with regards to that point around the number of referrals seeming to go down, I mean, the implication of that is that the number of people with long COVID is declining. Is that your understanding from the loss of referrals to the service?
Is that directed to me, Michael?
Any of you?
I mean, I'm happy to answer that. And actually, in terms of referral rates and whether that translates to number of people with long COVID, I mean, I've mixed feelings. I will say. So first of all, I will say that with vaccination rates going up and generally awareness of COVID, people, I would hope, are contracting COVID-19 less, and therefore long COVID may likely to be fewer in numbers. On the one hand. On the other hand, obviously we are very conscious of the fact that national testing is no longer the case across Derbyshire, across many parts. There are some pockets where sort of care homes and things where these things routinely still happen, but other places they don't happen. One thing about our post-COVID service in Derbyshire is that from the beginning we've always not only taken people with positive test results, and we've always accepted patients who GPs have a strong clinical suspicion that they may have post-COVID, and this is something we'll continue to do.
Can I come back on that? Just there was a few things to worth clarifying. In terms of vaccination rates, well, we know that most people at the moment aren't covered by their vaccinations. They're way more than 3 or 4 months. And we know that vaccination has an exceptionally low seroconversion in long COVID. So you need to have lots of repeat vaccination. So I don't think that point's correct. I think we're actually quite lacking in immunity at the moment, especially groups like long COVID who aren't on the clinically vulnerable list. So we can't actually get access to the vaccine, and neither can we get access to things like Paxlovid. There was another point, but I think I'm blanking on what it was. Yeah, the numbers at the moment of people with COVID, as you say, yeah, we don't have any national statistics and we don't have any wastewater surveillance, which makes it very difficult to know how many people in the country do have COVID at any one time. The resource that we're using at the moment is the Zoe Health app, which is being used by the NHS, and that's currently stating over 1 million people. 1 in 10 of those are estimated to go on to get long COVID-like illness. So I find it very hard to believe that the rates of long COVID are actually declining. I think there needs to be an explanation for why referrals aren't being made to the service. Why aren't these individuals being recognised and beelined into the service? Because everything we're seeing on our social media channels, the amount of influx we get onto them, the new members, indicates that long COVID is not declining. It's just not being recognised because we're no longer testing for it and the public eye is no longer on it.
I think it's important to remember that a lot of people with long COVID obviously have a wide range of symptoms, and obviously we can only, as a post-COVID service, see what comes through our doors and the referrals that we get. I understand that it's important so that GPs get educated and refer appropriately to us, and also that the general population gets, we do health inequalities work and work out which groups of people aren't going to their GP to let them know of the symptoms as well. But once they're coming through our doors, then we are happy to support and treat people accordingly.
Thank you. Sorry, I keep muting myself there again. Rose, if we just come to you and then we'll move on to the actual engagement activity, if that's okay.
Yeah, that's fine. I've just got 2 points. First one was on regarding GP education, Fazia. You talked about educating GPs to refer those who don't have high referral rates. What about sort of the in-between phase where you've been referred? And I don't know if other people with long COVID are finding this, but you kind of between waiting, I know your waiting lists have gone down for your clinics and hubs, because I've been told that on phone calls, but that period in between where you're sort of left in limbo and GPs are like, well, referred you to long COVID clinic, you know, you're being sorted by them, but you've still got issues that might need to be dealt with at that time. Is that education being directed towards that kind of like, it's almost like you've been referred to long COVID clinic and now you're off their radar and out of their hair, and I know that's sort of like reducing what they feel about it, but it feels like that for us.
So at the moment our waiting list's about 6 weeks.
Okay, that's good.
And we acknowledge that before then, when the numbers were a lot higher, our waiting list was a lot longer. But now with the 6-week period, our GPs are aware of sort of your COVID recovery and other kind of self-help material and things that they can direct patients to while they're waiting to come into our service, and we within the service also kind of get, try sort of with when we give out the kind of first appointment letters and things, we do try and direct people to material that's out there that can be used in the interim. So that's kind of how we try to help in that gap.
Thank you. Yeah, that's good that your waiting times are down to 6 weeks. Second point was on sort of inequality. I know you touched on inequalities to do with people getting referred. What about sort of inequalities to do with clinics themselves? I know it might be something that's on Twitter, but being on social media in those long COVID communities, we hear about the inequalities between different clinics and the services they're offering us. We read about places in London where we get wonderful yoga, sort of like, I don't know, it seems like this health spa. I know that's in my head probably, but you know, I think there is definite inequalities between services. Are you trying to work together to sort of improve services everywhere, or are you still sort of very separate?
I mean, in terms of variation in services across the country, I guess two things. From the perspective of what we've been trying to do to get everybody on par is this kind of education material that I mentioned that we've posted onto Health Education England. We've asked all of the post-COVID services across the country to their clinicians to access that and go through those learning modules, and so that at least the kind of the material that's coming out of these services are somewhere similar. In terms of what I was going to say, baby brain. So in terms of
the offered
what was your second part, Rose? Sorry?
It was to do with tying up together and seeing if I know some of that may be out of your control, but I didn't know if like sort of coming from a central point or sharing information, sharing where things works and experience and what's working might help.
So sharing wise, we are regularly sharing with NHS England what we do in Derbyshire, and there will always be some variation. I think there needs to be an understanding that there will always be some variation in terms of the makeup of the clinics. Not everybody has lots of vocational rehab specialists. Not everyone has chronic fatigue specialists and things like that within their own counties. We are quite fortunate that we do have these specialties that also are available in London. But I do recognise that across the country it's not the same.
Okay. And just maybe
Sarah,
sharing online and that kind of thing, you know, just as like some improvement thing. Just if you can't share people, can you share sort of online, make more of the use of the online? But I understand, I understand that's sort of out of your control a bit as well.
Could I just add a commissioning point just to that as well, Fosie, just to note that in Derbyshire we do comply with national guidance, so we are meeting national guidance and we are identified as a beacon of good practice. So that's what I would add to that as well. Although there you'll see differences in other regions and areas, we do comply with the guidance which is expected of us.
So did you have a comment coming on this discussion? Yeah.
I just wanted to say that so all the heads of ICBs come together on this national task force and feedback, and one will do a presentation each time, and information is shared. I think that's the important thing to know, Rose. Information is shared and best practice is shared where appropriate, and you know, people join up together, but there isn't the time. Staff clinicians don't have the time to actually visit each other and have long conversations. And I actually as well, and I do want to say this very, very clearly, my experience of Derbyshire long COVID hub is that it's one of the better ones. It really is. I think we're very, very lucky to have the service that we have in Derbyshire, and that's, you know, that's me hearing about lots and lots of others all around the country. So I want clinicians here to hear that, and the engagement team to hear that the service that we have in Derbyshire is a really good one. What I think from a health inequalities perspective, I think people give up because they're so exhausted, and I think we have to be careful that this doesn't turn into a patients with long COVID trying to justify the fact that they have long COVID, because that's what we have to do every single day of our lives. And I think the the information about people with long COVID, the referrals going down, I think it's so subjective and it's so divisive because we don't have the ONS data anymore. And what's being reported at the moment are people with long COVID down to 300,000, but they're the people who have got organ failure and can't operate without clinical assistance day in, day out. Now, I'm not as bad as that, but I have developed an autoimmune disease. I have got POTS, I've got MCAT, I wear hearing aids now. But what I want to reiterate is that Derbyshire hubs are really good, especially in comparison to other ones that I've heard. And keep that to yourselves, probably.
Thank you, Sarah. Thanks very much for that. Obviously, there's a lot to talk about, and I get that, but we do want to get on with the actual part of the engagement part of it now. So I've just talked very briefly about what the engagement approach has been. So we wanted to come up with a different layered approach. So everybody had a way of actually coming in and giving their point of view and giving their experiences. So we have had the survey that is going live over the whole month. We've got 5 workshops, which we are 2 of the virtual, and then we're doing 3 face-to-face, 1 in the north, 1 in the south, and then 1 in the Harrison hub as well. So we're doing that all over this next month, and obviously following that, we'll put everything together and put it in a report as well to kind of put what everybody said. So I'm going to share my screen now, and I'll go through the PowerPoint that I've put together. Can everybody see that all right?
Yeah, we can both. Thank you.
Okay, wonderful. Sorry, I can't see anybody now. Okay, I can only see Sarah, so that's all right. So the engagement workshop review. So we are if you want to, we are doing Slido. So if you take your phone and take a picture of that QR code, it will take you to the set of questions. You'll only move on when we move on the slideshow. But it means that you can tap away while you're listening and put in lots of different answers. It doesn't say your name, it's all anonymous, so you can type whatever you want to. So just a little bit of housekeeping. So just listen with an open mind, respect each other's views, and stay muted if somebody else is speaking. On here, if you've not used MS Teams before, Microsoft Teams, there is a big bar that's going across the top of your screen. There is a little speech bubble that says chat, and that's how you can open up the chat. So if you don't want to do the Slido technique of putting your feedback in, you can answer the questions in the chat box if that's your preferred method. If you would prefer to talk, you can raise your hand by pressing the hand, and that will raise your hand. I'll go to the next one. So how is it going to work? So I've just gone through those different 3 ways. So you could do the Slido to give your response. You can raise your hand, or you could put a response in the chat box. Even. There's 3 areas we're going to cover in the questions. So we're going to look at the current service experiences. So what do you feel is working well? What do you feel is improving? And then we're going to look at access, so how you're accessing the service, and then looking at the future service as well. So in the big case for change documents, what the team did was they contacted everybody who does services, support groups, and asked them about what patients' experiences were from the current services. And this is what we got. So in the yellow box is more the positive side of things that people were saying. So it was mainly lots of positive comments around communication, feeling they listened to, opportunities to ask questions, staff particularly, that the professional, supportive, helpful caring, the treatment and care that was actually given, and that the hubs gave them a better understanding of the condition. There was only a few comments around what needed improving. The one that I think this had around about 3 comments was around travel and wanting a service closer to home. And then there were individual comments around having a bad experience with a particular consultant, a lack of psychological support, feeling that they're struggling, then the waiting times as well. So that's what we've got so far. So that's what we want to expand on. So this is the first question that's coming up. So if everybody's happy to join the Slido, the QR code will be at the side of every question as well. So the first question is, what do you find that currently works with the service? So if you just think about anything from, it could be the way that you accessed it, the waiting times, the treatment and care, discharge, communication, all those different kind of aspects. What thing did you think worked well? Fatigue care. That's wonderful. I can't see if anyone's got the hand up, Mark, so please pipe in if anyone's wanting to speak.
Yeah,
or...
don't worry, I'm keeping an eye on that there.
Okay, wonderful, thank you. Yep, so care. Holistic approach of the clinical and psychological care has worked really well, also responsive to new symptoms as they emerge. So care treatment, we've got communications, again, communication around email responses, advice, yeah, staff as well. And communication, staff again. Got a couple about waiting times as well, I've seen as well. Treatment, staff again, advice as well. Yeah, thanks for that. That's really good detailed stuff as well. Sorry, so my first time using this as well, so I'm a bit new to this. Staff brilliant care and communication. Yeah, so staff again, and then again communication as well. So yeah, thank you for that. So we'll move on to the next question. So this one is around, what do you feel be improved with the service? So again, thinking of all those different aspects around how you access the communication, the staff, the care and treatment you receive, the discharge. Okay, yeah, so that's kind of like signposting a bit there that could have been improved. Okay, repeating information as well, yeah. Okay, lack of knowledge, yeah. Waiting times, gap between contact. Oh, what's the acronym there? Someone's put LCHBS as
It's long COVID,
COVID
hubs.
hubs. Right,
I
okay.
missed, sorry.
It's all right. Discharge and then support as well. Ooh. No, there was a Derby app. Derby on reminders of appointments 1 week before. Is that kind of, is that point? So I'm just reading, didn't know there was a Derby, a WhatsApp Derby on reminders of appointments 1 week before. Right, okay. Yeah, it's a bit of continuity, lack of continuity. Okay, yeah, around discharging then. No group for chest or meet-up areas. Okay, I think that's everybody. A big range of different areas there as well that everyone's commenting about. I'm not quite sure. Well, at the top here it says treatment, time, care, and it says 3. So I don't know quite what that means. Lack of understanding of PME. What does PME mean? Sorry to ask.
Post-exertion malaise.
Right, okay, thank you. Okay, thank you for that. Move on to the next question. So this is more about what's important to you when you're being discharged. So this is obviously if you've not been discharged, what would be important to you? And if you have been discharged, what was important to you? Okay, yeah. Yeah, I think all of those different things have a bit of communication connected, don't they? They're just wanting to know what's actually happening. Yeah, I think everyone's typed there. Again, some really good detailed, loads of different ranges of answers as well. So thank you. Oh no, someone's still writing, sorry. Just tells me at the top. I think everyone's finished. I'll move on to the next slide. So this next section is more about access. So how did you or do you access the service? So I think you can obviously, if you do different types, then obviously I think you can click the other types as well if you did a phone, bit of face-to-face or online. It's mainly on the phone. Got about 30%. Sorry, Sarah.
Could I just say there that wasn't none of the ways I interact are my decision. I'm either told it's face-to-face, online, or on the phone.
Right, okay. If everyone's feeling, we'll move on to the next questions. Hopefully you can probably will mean be able to put a bit more to this one, Sarah. So what would be your preferred method of using the service? Yeah, so it's a bit of a mixture of wants, isn't they? Face to face or telephone. Okay, thank you very much, everybody. So if you did have to go to face-to-faces appointments, did you feel that the travel time / distance was reasonable for that particular appointment? Just a bit more of a kind of a little bit of a poll. So now we're moving on to the future service. So what would you say the most important things to you are in regards to the future service? Okay, so what about the types of treatment? Medications. I think quite a few around psychological support, understanding. Yeah. Okay, thank you. Lots of detailed answers again. Yeah. Okay. So there's been some high level opportunities for change that have been started to be developed. If I could ask Scott or Sam just to come in here, just to go into a few more details. These are only the initial opportunities, so I'll let Sam speak.
Yeah, of course. They're 4 opportunities, very high level. No decision has been made whatsoever. We're just looking at them. So option 1, as we call it, is the post long COVID service is stopped in Derby and Derbyshire, and patients are signposted to your COVID recovery website and any other existing services that are out there for support. Option 2 would be to develop existing services to meet the needs of long COVID patients. That might be other areas of rehabilitation where we may look at extending that what they already do to offer criteria to meet the need of long COVID patients. Option 3 is to allow the service to continue running as it currently is, but with reduced staffing and funding. As we mentioned, Scott mentioned previously, we know that referrals have reduced and NHS England have let us know that there will be reduced money. And option 4 is to develop a service that provides support for existing long COVID symptoms and understand if there are any other symptoms for long-term conditions that could be included in the programme. So widening the net out a little bit more to offer rehab to other people who may need it.
Okay, thank you, Sam.
Does anybody want any more on that, or is that sufficient at the moment?
I think if we go on to
do you want comments on that, Sam?
Yeah,
you can
so
do, yeah, you put comments on, or if any questions. Yeah, I mean, I've seen people are putting comments in the chat box.
yeah,
Sarah.
I mean, the next question is around people's initial thoughts about those potential opportunities.
Sorry.
More than welcome to put it in there, Sarah, or talk, whatever you prefer.
And Michael's got his hand up as well, Beth.
Okay, Michael. To go in with Sam.
Sorry, yeah, it was to comment on those, but are we going to do that in the next part?
No, you can comment on that now. That's absolutely fine.
I guess I can't see them now, but the first one was to cancel the service, to close the service. I think the issue, big issue with that is that there are a lot of people with long COVID, and they're suffering. You know, literature suggests the quality of life of these patients is comparable to those with stage 4 cancer. So by removing this service, you have to be honest with how much suffering it will create for people, because they won't have any support. They'll be sent to a website. Can you imagine being sent to a website for any other condition that reaps so much suffering on the patients? So I think the first option seems wildly inappropriate, but I understand why it's on the list of potential opportunities that you're thinking of.
Thank you, Michael. Sam or Scott, did you want to come back to Michael?
I think we're just to say that we have to, none of them, they're all high level options, no decisions made, and just to say that, you know, we were just looking at all options, which, you know, in any options appraisal or opportunities that come forward with any organisation, you always have to look at one of the worst case scenarios, which is, you know, do nothing at all, which would be just stop the service. But it's not the one that anybody wants to go with, but we have to have a fair and equal spread of options, if that makes sense.
Yeah, just to add to that as well, Sam, is because we've had no confirmation on finances for 24-25, it needs to be taken into consideration. I think just another point, because I've been looking at some of the comments coming in the chat. I think a bit more clarity probably needs to be given on option 2 as well, Sam. It's just to make sure that participants are clear what we mean by option 2.
Okay, so for option 2, instead of it being a long COVID service, this will mean that we will provide money to other rehab services who will need, so for example, and I'm just doing an example here, a fatigue service. So rather than it being the long COVID service, we might say we'll give the fatigue service X amount of money to booster up their service they offer and change their criteria or amend their criteria to allow long COVID patients to be seen within that service. That's just one example. It's not saying that's what's happening. It's just literally an example. Yeah, but it's mainly around, a lot of it's around the acceptance criteria for the other rehab services that are out there, because they won't accept, or they don't accept, their criteria is so strict that it doesn't meet. It's for a long COVID patient to get through and be seen.
Is it okay to come in there?
I'm sure Beth will let you come in. Yeah.
Yeah, sorry, I can't see the screen very well.
Sorry.
No worries, Beth.
My hand says number 1.
Yeah, I've got it, Sarah.
Sam, I think the most strategic way forward really is to join in as many other existing services as possible, and persuade other rehab services in some way to take on long COVID patients, and you know, the CFS and the post-exertion malaise that people experience. I had fibromyalgia before I caught long COVID, and I've forgotten why I was going to say that. But I think the other thing is involving patients more, because actually there is the first part of this consultation. Sorry, I've got cognitive stuff. The first part of this consultation felt as though I was in any kind of other environment where I have to defend myself, and I have to defend the fact that I have long COVID and long COVID exists, and there are lots and lots of other people that have long COVID and still have it. And it's only when I'm with other people with long COVID or clinicians from long COVID hubs or services that I don't feel as though I have to justify or advocate for myself. And it's such a relief to not have to do that. Involving patients more to run or to co-facilitate just meetup services online, just doing things like that to expand the service, that if the funding is reduced, we don't know if it's going to be reduced. If it is reduced, then using the resources that are available to the hub and to all the patients, it's about using the skills that we all have, because there's so many of us that have had to step down from long-term careers. They still have so much capacity to give, and I think that's why I became a PPV. I felt like I was getting my own back on long COVID, and to involve the charities as well. There are other places where resources can be found, I think, is what I'm trying to say.
Thanks, Sarah. Just to let everybody know as well, I've moved on to the next question, and it's about anything else that we need to be considering. So obviously there's just a space there for anything else that you'd like to put in regards to the review. Michael, I'll come to you. I'm just conscious of the time as well. Michael?
Yeah. So I guess one of the problems that I've had is that there's a lack of, I don't know whether it's curiosity or capacity because of funding to actually try and determine underlying pathophysiology and get targeted treatments. So you end up rehabbing before you have any idea what's wrong with the patient. You just put a sticking plaster and hope it works. And that works for some patients, but an awful lot of patients, 50 to 60% of them, they're fitting criteria for ME/CFS, and a lot of them have profound dysautonomia. Okay, and the rehab techniques that are being used, they're just not sufficient on their own. Yeah, we're not actually bunging the hole in the leak. So the service needs to change so it actually is helping patients truly recover, as opposed to just accept this new disability.
Thank you, Michael. Fawzia, would that be something you'll be able to come back to Michael on?
So in terms of what we do within the Derbyshire post-COVID service, when you first come into the service, you have an assessment with a GP, and there, based on your symptoms, further tests are done by our physios and occupational therapists within the assessment service before you're moved on to the rehab element of the post-COVID service in Derbyshire. In that time, there are tests like active stand test, lying, standing blood pressures, and other kind of tests that are done to and spirometry for that matter, to see whether there's any other underlying condition that's going on. And for example, that's when a diagnosis of POTS might be made. And there are treatments that we do start within the clinic for people with these symptoms, and where we have national guidance in terms of or NICE guidance that actually there are these conditions that have medications for treatment for them, and then we're able to prescribe them. We as a service don't necessarily do out of prescribing outside of NICE guidance. And I'm aware that there are a lot of things that are going on across the country that's that's not something that's generally recommended.
Yeah, thanks, Fawzia. So I'm just conscious of the time now. Obviously, it's 8 o'clock now. So thank you for everybody for all your feedback, and I wanted to just explain what happens now. So obviously this is the first of the 5 workshops, and we've got the rest of the workshops over the next month. And following those workshops, we will produce a report from all the different engagement events that we've done, and that report will then be fed into and influence the development of the potential new options. So that report will be available, and we'll upload that onto the engagement platform. And I'll put a link here on that paper that's been sent out to everybody, so you can follow what happens with the review on there as well. I'm just going to stop sharing my screen and come back to the room properly. I know Mark said that the chat's been extremely busy, so obviously we'll go through that as well. Mark, if you're able to put our email address in the chat box as well, so if anybody's got any questions that they would like to get a response on as well, if you drop us an email, and then we'll make sure that we can get responses back to people as well. Has anybody got anything to say just as we round it up? Any last bits of words or anything? Sarah.
So I think just thank you. You know, the Derbyshire Hub, in my experience, is a really good one. I've been in touch with them for over 2 years, and they've really got me through some of the darkest days. And I think involving us, I know you have to involve us, but involving us and really listening, and I feel really listened to because of the people that are here. So thank you to everybody who's come here and is listening and is genuinely hearing what we're saying. The service that Derbyshire provides for me has been life-saving, literally.
Thank you, Sarah. That's really good to hear as well. Joanne, I'm not remembering your name right. I've got JG.
Yes, hello. Thank you for this. I can't access the chat, so could you tell me the email address, please, that you talked about?
Oh, sorry. Yes. Mark, are you able to tell the chat?
I can read it. I can read it out. It's DDICB dot engagement, and then that's at nhs.net.
Right, thank you.
You're welcome.
Yeah, and Mark, if you're okay to put it in the chat group as well, just so if anybody's got any questions that they want to get a response back to, that'd be brilliant as well. So if anybody's got no more questions, I would like to thank everybody for coming again tonight. Please carry on following us on the engagement platform. Also, obviously, drop us an email if you've got any further questions as well. And I'd like to say good night to everybody.
Yep, good night. Thank you, everybody.
Thank you very much.
Good night.
Thank
Thank
you.
you.
Thank you.
Thank
Bye.
you.
Thank you.
Bye.
Bye-bye.